So, dear Chairman, dear colleagues, I'm Paolo Bima. I'm actually working at the Cardiovascular Research Institute in Basel. Today, I'm presenting this project, diagnosis of acute myocardial infarction in patients with active or past cancer. So, what do we know? We know that cancer and thrombotic heart disease are deeply interrelated. First of all, because traditional risk factors such as old age, cigarette smoking, obesity, diabetes, they can both cause cancer and thrombotic heart disease. Then we have the fact that cancer activates platelets and promotes inflammation that in turn promote thrombotic heart disease. And then finally, chemotherapy and chest radiotherapy that are used to treat cancer, they can both cause acute and chronic heart and vessel damage. So our working hypothesis was this one, was that what if a patient with active or past cancer presents to the emergency department with chest pain? So based on prior preliminary reports, we would expect higher prevalence of non-cardiac causes of chest pain, such as cancer-related pain. And then we would expect a lower accuracy of high-sensitivity troponin T. So let's jump to the methods. So the cohort that we used was the APACE study that Alessandra has just presented to us. Then the patient, as you said, we enrolled patients with acute chest pain presented to the emergency department, and we excluded patients with end-stage renal disease on chronic dialysis. So we acquired some more cancer-related variables, such as cancer subtypes, date of diagnosis, the fact that it was active, inactive, advanced, or early stage. And then we defined our endpoints. The first one was to define the prevalence of non-STEMI in the cancer population. Then the assessment of the likelihood ratio for acute myocardial infarction of predefined chest pain characteristics and ECG findings, and their dependency on cancer status was assessed via a p-value for interaction. Then we wanted to assess the global diagnostic performance of high-sensitivity cardiac troponin T, and this was done via the area under the curve of the RUC curve. And then finally, we assessed the safety and efficacy of the ESC 0-1-hour algorithm. And we externally validated all these endpoints in another international multicenter diagnostic study called the TRAPID AMI study. So let's jump to the baseline. Among more than 8,000 patients, we had 711 patients with active or past cancer. Of those, 592 had a solid cancer, 98 an hematologic cancer, and 13 had both. So about the baseline characteristics, cancer patients were older and had more cardiovascular risk factors, such as previous MI, hypertension, dyslipidemia, and diabetes. The final adjudicated diagnosis, we can see here in brown are always depicted cancer patients. We can see that the non-STEMI prevalence was much higher in cancer patients. And about the non-AMI diagnosis, we saw that cardiac non-coronary causes of chest pain were more prevalent in the cancer population, while non-cardiac causes were less prevalent. Then the predictive ability for AMI of predefined chest pain characteristics and ECG findings, they were all comparable, except for ST depression. As you can see, in cancer patients, the positive likelihood ratio was lower. And here we can see the baseline high sensitivity cardiac troponin T. On the y-axis, we have the levels of high sensitivity cardiac troponin T, and on the x-axis, the final diagnosis. So here we can see that not for non-STEMIs, but for all non-AMI final adjudicated diagnosis, the median troponin value was higher than in non-cancer patients, and sometimes it was higher than the 99 percentile that you can see with these red dashed lines. So consequently, we assess the accuracy of baseline high sensitivity cardiac troponin T via ROC curve. Here we can see in non-cancer patients it was 0.94, in cancer patients it was 0.89, and the difference was statistically significant. Then let's jump to the ESC 01-hour algorithm. So for the rule-out group, we assess the sensitivity. And we can see that sensitivity in cancer patient and non-cancer patient were comparable. Then in the observed zone group, we assess the proportion of patient triage to the observed zone. Here we can see that twice as many patients with cancer as without cancer are triaged to the observed zone. About the rule-in, we assess the specificity. So we can see that specificity in cancer patients was lower. All these results were externally validated in a TRAPID AMI study, and the results were comparable to the PACE cohort. So I want to highlight a couple of major limitations of this study. So causal inference should not be made based on this result. We didn't perform analysis to unravel causality. And unfortunately, no specific sample size calculation was done, so we might be underpowered for certain subgroup analysis. In summary, what we saw was that NSTEMI prevalence was 1.5 times higher in cancer patients than in non-cancer patients. Then chest pain characteristics and ECG findings, excluding ST depression, maintained their diagnostic ability for acute myocardial infarction. Then we saw that the global diagnostic accuracy of high sensitivity troponin T is decreased, as we saw in the ROC curve analysis. And then, most importantly, the ESC 01-hour algorithm is very safe to be used in cancer patients. But the drawback is that rule-in specificity is decreased, and also more patients are triaged to the observed zone. Thank you for the attention.
Excellent presentation, and we have a question from one of the great leaders.
Thank you. Interesting data. I think it will be very important if you tell us the difference between chronic cancer and acute cancer, because I think you really put together, you group it two different clinical situations. Do you have this data?
Okay, so thank you for the question. We didn't really define acute and chronic cancer, but we did define actually active and inactive, which is that thing that you say, yeah. So I haven't presented the data, but actually we did a subgroup analysis in the ROC curve analysis, for example. So for active versus inactive, advanced versus early stage, and we saw that the decrease in diagnostic accuracy was consistent among all subgroups.
So no difference between two groups?
No, we didn't find any subgroups that might have explained that reduction.
Okay.
No, thank you very much. I have a question. Actually, I've brought this up before in the APEX trial. So when you say the people that were entered into it had chest pain, so in the evaluations that we do for high sensitivity troponin, it's always clinical suspicion for AMI, which includes chest pain, but also many other things that clinicians go, it's an old person, it's a diabetic, I don't know. So did all these people have chest pain, or did they have other symptoms? I just would like to clarify that.
Yeah, thank you for the question. So it is true that the main symptoms for which patients were included in the PACE study was chest pain. But it's also true that we also included patients with dyspnea, nausea, and so we have also the data for that.
So I think it would be, in the presentation, we better, the patients that were entered were people the clinician had suspicion for AMI. Because I think when you just say chest pain, it is a little confusing. You know, in our institution, about 10% of patients that come in who have an AMI do not have a primary complaint of chest pain. So
yeah, it's true. Atypical presentations are possible, but then you can, in those patients, you suspect an acute myocardial infarction either with clinical gestalt or after your lab or your thorough clinical and laboratory examinations is done. And this was a prospective study, and yeah, suspicion of MI is true, but it's more true chest pain. So we have also a lot of patients presenting with the atypical chest pain, so left side, right-sided. Thank you.
Okay, we have one more question. This has to be our last one. Danielle?
Thank you for a great presentation. Just one question regarding, have you considered that probably because they go to observe zone, because they may have like chronic elevated troponin levels, maybe because of cancer or because of chemotherapy, and that's why they go to the observe zones? Do you have any data about baseline troponin before they present to the emergency department? Because if they're treated in the hospital, sometimes they do this kind of monitoring. If you do, it would be interesting to compare that.
Yeah, thank you for the question. It's a really good point. In APACE, we didn't record the data about previous troponin levels, but it's true that you can do a kind of similar analysis considering the final adjudicated diagnosis. So it is true that in the observed zone, the most common diagnosis was non-cardiac pain. So maybe they had really a chronic troponin elevation for whatever causes that we don't know from this study.
Great job.
Thank you.